Hi guys, I'm going to talk about trauma, crisis, disasters, and any related disorders. So we know crisis, if patients are going through crisis, if they're going through disasters, right, that can lead to different traumas. So we're going to just encompass all of this within this chapter. So let's get started here. So we know that trauma can shape an individual's worldview. It can impact their daily lives and their ability to function. So as we define trauma, it is any disturbing experience that results in significant feelings of fear, confusion, and disassociation that negatively impacts an individual's behaviors, their attitudes, or their functioning. It's not common and can occur anytime during an individual's lifetime. It leaves invisible wounds, altering neurobiological development, attitudes, behaviors, and social functioning. An individual's life can be changed as traumatic events can alter their sense of inclusion and belonging. And it really changes their perspective, resulting in a perception that the world is not safe, it's not supportive, it's just and a predictable place. When we think about crisis, this is a situation or an event which causes emotional or cognitive stress to those involved. Disasters are an incident or an event that could end human life or cause health-related harm, requiring immediate response in resources and workforce. Both crisis and disaster are traumatic events in the lives of individuals and possibly communities. These events have been described as natural disasters and human-caused disasters, each having the potential to cause catastrophic injury, damage, and death. So when we think about our natural disasters, these are geological or weather-related events that have the potential to cause loss of life. So I think about tornadoes, floods, hurricanes, wildfires, earthquakes, and maybe even droughts. Those are all of our natural disasters. On the flip side, those human-caused disasters are situations or events that result in loss of property, physical and emotional injury, mass casualties, mass violence, or death. Can really impact, again, those individuals or our communities. So what are some examples of our human-caused disasters? The first one that probably comes to mind is that mass violence, right? Those school shootings, maybe industrial accidents or acts of terrorism such as 9/11. War could be a human-caused disaster or even mass trauma. So this slide just again goes through some examples of some adverse or traumatic event experiences that individuals can endure. So we've talked about natural disasters. Those are those hurricanes, earthquakes, floods. Human-caused disasters can include those mass shootings, mass violence within the community, maybe war or terrorism. Some events or experiences can be individual as far as like car accidents, fires to the homes, sudden or unexplained separation from loved ones, maybe even physical, sexual, or emotional abuse and neglect. Poverty is an adverse event, right? We don't grow up to live in poverty. We don't want our parents to raise us in poverty, right? Those are examples of some of those adverse experiences. Other ones can include racism, discrimination, and oppression. So just being really mindful of those traumatic events or adverse events that our patients may be experiencing. An understanding of the types of traumas and the effect trauma has on the individual is really foundational for providing trauma-informed nursing care. Trauma can have lasting effects on an individual's ability to function mentally, physically, socially, and spiritually, really resulting in disruption of well-being. When an individual is exposed to trauma, their response can manifest as intense fear, feelings of confusion, disassociation, or disruptive emotions, which may have lifelong effects on their mental and physical health. When we think about the types of trauma, you can see here there's acute, chronic, complex, system-induced, vicarious, and historical. So acute trauma is a single traumatic event. It's limited in time, things like a car accident or a natural disaster. Chronic trauma is exposure to multiple or persistent traumatic events. So I think about abuse, social emotional neglect, maybe isolation, poverty would fall in that chronic trauma, maybe even hunger. Complex trauma is exposure to chronic trauma that also distorts that individual's fundamental sense of self. So if I have persistent social inequities, maybe I have persistent racism against me, discrimination due to sexual orientation or gender identity. That's that very complex trauma that kind of targets that fundamental sense of self. System-induced trauma is that trauma that's experienced during movement through organizational systems. So system-induced, I think about the foster care system, maybe our juvenile detention centers. Vicarious trauma, also called secondary trauma, is an indirect trauma that results from engaging with victims of trauma. So maybe those healthcare personnel during COVID, first responders after 9/11, or maybe our communities that were involved with Hurricane Katrina. That's that vicarious trauma. That's an indirect trauma working with those that have been through a traumatic event. Historical trauma is that psychosocial distress resulting from trauma or adversity passed down through the generations of groups of people who share an identity, an affiliation, or a circumstance. So when we think about our attachment disorders, these are typically disorders of childhood who have problems with emotional attachments to others. Reactive attachment disorders have consistent patterns of inhibited, emotionally withdrawn behavior. They're unresponsive to caregiver efforts to offer comfort in distress. Disinhibited social engagement disorder, children typically demonstrate no normal fear of strangers. They're seemingly unfazed by separation from their primary caregiver. So these children tend to be overly friendly. They're usually willing to go with someone they don't know. Both of these disorders are rare, even in high-risk situations. But without treatment, attachment disorders may have lifelong consequences, including a lack of trust, not feeling secure in friendships or partnerships. Children, however, tend to be naturally resilient, and with support, they can learn to develop those healthy relationships. Treatment always involves both the child and the caregiver in individual and family therapy. For young children to flourish, safe and supportive relationships are necessary. So the autonomic nervous system role is to ensure that the individual maintains homeostasis through our defense mechanisms such as fight or flight. So you can see here, what does that entail? Our peripheral autonomic nervous system, we have our parasympathetic and our sympathetic. So I'm going to just have you just be aware of trauma and how it really the autonomic nervous system is affected to try to maintain some homeostasis for our patients enduring that trauma. The polyvagal theory basically is showing how the body is responding to trauma. So when we think about our sympathetic, which is our fight or flight, often the initial defensive response includes increased heart rate, shallow, fast breathing, muscle tension, because our bodies are preparing for that mobility, that movement, and dealing with the stressor. Our dorsal vagus is that faint or freeze. So this response involves shutting down and is often viewed as a second line of defense. It often presents as a diaphragm breathing or as visceral response such as GI issues. This occurs when the fight or flight is not possible and freezing is needed to preserve life. And then the last one is the ventral vagus, which is our fawn or social engagement. And this response is evident when the individual uses social skills to become connected to the stressor or engage in communication through social engagement. So you can see different trauma responses and how that polyvagal theory can come into play. Trauma and adverse conditions can trigger the body's internal stress response system, as demonstrated by the hypothalamic pituitary axis, which then regulates our stress. The hypothalamic pituitary axis development begins in utero and continues through early adulthood. Distinguishing between types of stress is vital in the development of any individual. Stress can be positive and create a normal response. Anxiety about your first day of school, for example, right? Getting a vaccine can generate a positive stress response. When we think about tolerable stress, that's the initiation of the body's kind of alarm system going off. If it's activated in a child, this level of stress can be buffered by a supportive relationship with an adult, such as a parent. But this support system acts as a protective factor for the child and allows that brain and other organs of the body's time to recover. Toxic stress occurs when a child experiences frequent significant adversity without receiving that support from that adult, that parent, that caregiver. So this may include living with abuse, living with neglect or fear. This level of stress can disrupt development of the brain and other bodily organs, increasing that individual's risk of developing a mental illness or chronic illness later in life. Chronic exposure to trauma and stress can result in toxic stress, where the body learns that the experiences of fear and trauma are normal. So as we continue just to talk about toxic stress, this describes the wide variety of biological and physiological changes at the molecular, cellular, and genetic levels when an individual experiences significant or prolonged exposure to adversity. Toxic stress results from prolonged activation of that stress response, preventing the body and the brain from fully recovering. Toxic stress can manifest in children and in adolescents. So when we think about developmental, such as developmental delays, it could be failure to thrive, maybe learning difficulties. Some of the behaviors that we may see maybe engaging in risky behaviors, such as early initiation of sexual activity that could lead to unwanted pregnancies, early initiation of smoking that could lead to lung cancers, physiological or physical manifestations. You just are at increased risk for infection, maybe things like asthma. And then the last one there is mental health concerns. So suicide attempts can be manifested with that toxic stress. So the key idea with this is that the prolonged activation of that hypothalamic pituitary axis, right, leads to chronic inflammation, therefore increasing our patient's individual risk for trauma-related disorders and medical comorbidities. So just as we see behavioral, social, physiological, mental manifestations in our kiddos, our children and our adolescents, we can also see those manifestations of toxic stress in the adults population as well. So as we look at behavioral, again, risk of intimate partner violence, sexual violence, risk of multiple sexual partners, sexually transmitted diseases. As far as social, financial stress, lower quality of life, physiological or physical examples could be ischemic heart disease, increased risk for infection, and then mental health, again, substance use, suicidal attempts, or even depression. So lots of manifestations with this toxic stress. As far as historic trauma, we talked a little bit about that, right, as generational. So this is a term initially used to describe the psychosocial distress resulting from trauma or adversity that's passed down through our generations. This term has broadened to include the psychological distress impacting an individual or group's cultural sense of physical and mental well-being, like in the aftermath of colonialization, maybe slavery, genocide, coerced assimilation, extreme poverty, or even mass casualty events. Common protective factors when we're thinking about trauma-related mental health events. Protective factors can be understood as social developmental, physiological, physical, mental health, and behaviors or practices. So as far as social development, secure attachment as a child, right? If we have a stable household, we're meeting those developmental and cognitive milestones. If we don't, right, then we're going to struggle. Our kiddos are going to struggle. When we think about physiological or physical health, again, if we have good health, healthy diet, exercise, sleep, right, it's going to be a protective factor from those health-related physical symptoms we can get with trauma. Mental health, or belief that they can impact or change the situation, right? It's learned positive coping skills. They have a sense of hope. Behavioral practice is that ability for the emotional self-regulation. So definitely some different common protective factors that kick in. So as we move into a little bit of disaster management, there is a cycle. The Future of Nursing 2020-2030 report indicated that in the past decade, that more than 2.6 billion people worldwide have been affected by disasters and crisis. That's creating a significant public health emergency. Nurses from all levels of practice are being called to respond to these crises and disasters. So the nursing role and responsibilities are best understood in relation to what phase of disaster are we talking about. Are we in the prevention phase, the preparedness phase, response, or recovery? So during disasters, nurses can be called upon in any of those phases. Save, rescue, triage, which can include assessing of mental health, emotional state of clients or communities. So this is an aspect of that ongoing triaging, monitoring, caring for both the physical and mental health needs. Crisis is a life event that can pose a threat to an individual and often requires an immediate response or intervention. The individual's underlying vulnerabilities impact their mental health state. So vulnerabilities can include, have they been through trauma previously? What is their socioeconomic status, such as poverty or homelessness? And what do they have a support system? So the crisis or event can act as a trigger, requiring immediate response or intervention by our trained individuals. So the key idea with this is a crisis is an aspect of disaster. However, an individual may experience a crisis without disaster. A crisis is a life event that is a threat to an individual and often requires an immediate response. The goal of applying crisis intervention is to help the nurse guide the client to an appropriate resource or select the therapeutic interventions that help that patient return to a more equilibrium after the crisis. So disasters can be human caused, natural disasters are, and then what is the impact of the disaster? So again, we've talked about these, we've given those examples. Again, those human caused disasters are industrial accidents, oil leaks, right? I don't know if you guys can remember like the oil leak out into one of the oceans. I think it was the Pacific. Acts of terrorism such as 9/11, or sorry, 9/11, or the mass shootings. Natural disasters are those weather patterns, right? Hurricanes, tsunamis, wildfires, things like that. So how is the impact of the disasters? We can think about emotional responses and physical responses. When we think about our emotional responses, remember people may experience a wide variety of emotional responses to possible catastrophic losses, including grief, bereavement, a change in their role, maybe a loss of life or property. Physical responses may cause housing displacement, create economic instability, or food insecurities for our individuals and those communities. So I really think about Hurricane Katrina, right? How many people lost their house, were displaced, didn't know where their next meal was coming from, right? That is the impact that disasters can have on communities and families and individuals. So globally, more than 70% of adults have experienced at least one traumatic event, 31% have encountered 4 or more. That's a lot of traumatic events across of a lifespan. Fortunately, most people who experience trauma will recover without long-term impacts on health and well-being, but we can think about those populations that are prevalent for traumatic events, right? Women, adolescents, Black Americans, Hispanic Americans, Indigenous people, our LGBTQ+, our military, and our first responders. Those are populations that are very prevalent to these multiple traumas as they go through life. Post-traumatic stress disorder is the most diagnosed trauma and stress-related disorder, with more than 50% of these individuals describing their experiences of trauma as interpersonal trauma. Adjustment disorder is common, though the prevalence is usually, the prevalence in the general population is hard to measure because it's hard to screen for adjustment disorders. And then let's see, we talked about the population prevalence. Okay. So let's look a little closer at each of these: PTSD, acute stress disorder, and adjustment disorders here. So when we talk about acute stress disorder and post-traumatic, exposure to a traumatic event produces wide range of expressions of manifestations. So this could include intrusion manifestations, negative alteration in cognitive and mood. Some of the distinguishing features of these two disorders is your acute stress typically is going to last for about 3 days to 1 month post the trauma, where post-traumatic means it's gone on longer than 1 month and can be experienced indefinitely. So just understand the difference in how do I distinguish between this is acute distress versus this is post-traumatic stress. So acute stress disorder can occur immediately after a highly traumatic event, right? It causes anxiety. It may cause some type of detachment. So these symptoms typically persist for about 3 days or longer, but they don't last for more than a month. After a month, the stress response should be resolved, but if it isn't resolved, then it becomes PTSD. So when we think about post-traumatic stress disorder in our children and adolescent population, I've got some statistics here, and I'm going to read them because I think it's pretty overwhelming. According to the U.S. Department of Veterans Affairs, approximately 15 to 43% of children and teens experience trauma. Okay, if we're talking about 43%, that's 4 out of 10 children and teens experience trauma. Of those, more girls than boys develop PTSD. Nearly 100% of children who witness their parents' murder or sexual assault will develop PTSD. And then other alarming statistics with relationship with PTSD are for children who are sexually abused. 90% will develop PTSD if they're exposed to a shooting at school. 77% of those will develop PTSD, and about 35% who see community violence will develop PTSD. So what does that look like? It's a reduction in play or play reflecting aspects of the trauma, right? So they either lose their ability to play or their play reflects what they've seen. A lot of self-blame, detachment, estrangement, loss of interest in some significant activities. You will see mood changes, sleep disturbances, some hypervigilance, and loss of concentration in this patient population. PTSD in our adult population, again, this is going to begin about a month after that exposure, but symptoms delay of months or years are not common. So flashbacks, which is just that re-experiencing the trauma, can be very terrifying. When the person recalls a traumatic memory, physiological reactions kick in. They have that sense of terror in their stomach, their heart palpates, muscles become more tense, right? That person often does not know where these sensations are coming from, and they usually attribute them to something in the present or present circumstance, and the past then becomes kind of the present, if that makes sense. Avoidance of stimuli associated with trauma, causing that individual to avoid talking about the event, avoiding activities, people, or places that arouse memories of that trauma. Persistent symptoms of increased arousal or that hypervigilance can be evidenced by irritability, difficulty sleeping, difficulty concentrating, a really exaggerated response. And then they can definitely have alterations in their mood, depression, negative appraisals, lack of interest. A lot of times they have difficulty with interpersonal, social, or occupational relationships because that usually just accompanies PTSD. Additional manifestations of PTSD we can see within our adult and adolescent population is depersonalization and derealization. We've talked quite a bit about that. Let's see. In children, we may see kind of a time skew. The child recalls details of the trauma, but really in different sequences than they actually occurred. That omen formation, the child typically believes that they missed warning signs for the trauma and that they believe they can prevent future traumas if they're more alert. Post-traumatic play and reenactment is that compulsive repetitive demonstration of some aspect of the trauma that the child had to endure. Adjustment disorder is a milder, less specific version of acute stress or post-traumatic stress, typically precipitated by a stressful event. So may include things like retirement, chronic illness, maybe a breakup, but not as severe and they may not be considered a traumatic event. Adjustment disorders may be a diagnosis immediately or within 3 months of that exposure. Symptoms typically include forms of distress, guilt, depression, anxiety, anger, can be combined with other manifestations of distress as well. So the nursing role of care is not to repair or resolve our client's trauma. This is not viable, right? We can't repair the trauma that's already happened, but we can try to understand how that trauma has affected our patient's or our client's life. Trauma-informed nursing practice is a service-based approach that is responsive to the impact of trauma and emphasizes the psychological, biological, and physical safety of clients and healthcare providers. We want to make sure we're also utilizing that trauma-informed nursing care so that we can avoid re-traumatizing our patients. Understanding the cultural context of a client who has experienced trauma or is in crisis provides kind of a roadmap for our nurse to navigate potential barriers and promote healing. So when we think about the cultural ecological model of health, you can see that here it's a tool to help provide effective, equitable, sensitive, client-centered care. So we know that this model just reminds nurses that cultural humility begins with mutual learning between the nurse and their patient. When practicing cultural humility, nurses admit that they cannot always know everybody's experience or culture, right? We've talked about that. But what they can do is seek to respect it and appreciate the client and what they have experienced. So cultural humility, defined as a dynamic process of ongoing self-reflection that requires critical analysis of one's own implicit biases with the intention of engaging in respectful partnership with others. What does this do? It creates a safe environment for our patient and prevents traumatic re-experiencing. So it represents a shift. So instead of asking, why are you here? The nurse can ask, what has happened to you? When we think about culturally competent care, this again is an ongoing ability to understand, appreciate, and respectfully interact with the cultures and belief systems that are different from your own. So universal trauma precautions, if you can think along the lines of like universal precautions, right? Everybody gets universal precautions. Everybody should get universal trauma precautions. It's assuming that everyone has experienced trauma and we're focusing care on reducing the risk for traumatic re-experiencing. So take into consideration the impact of widespread crisis. I think COVID is a great example, right? We have to acknowledge that we've been through COVID. We have to assume that everyone probably has experienced some type of trauma through COVID. Using therapeutic communication, right? Caring, compassionate, non-judgmental way to speak with patients that makes them feel respected. Leaving no room for judgment, respecting culture, gender, race, ethnicity, sexual orientation, creating a healing and safe environment, right? That's that milieu environment that we've talked quite a bit about. And then practicing self-care. The nurse has to take care of themselves first. If you're not taking care of yourself, how are you expected to take care of anybody else? So make sure you're taking care of yourself is part of our universal trauma precautions. We can think about the 4 C's of trauma-informed care. So the 4C model can be a helpful tool to remember when we're engaging in trauma-informed therapeutic communication. So we listen to them calmly, we contain, we care, and we cope. So if we're calm, right, we're paying attention to how one feels, one who cares for those clients. Adjusting the volume, the tone of the voice to match that client's level of engagement. Containment, right? The nurse contains the amount of trauma information needed to provide that compassionate care. Care is through ongoing self-reflection, self-awareness, and learning. And then when we think about cope, the nurse practices that cultural humility and applies empathy to interactions with positive regard for clients' coping mechanisms. So when we think about crisis interventions, we know that crisis does not just spontaneously happen. The goal of mental health nursing is to avoid crisis and reduce the likelihood that clients will escalate. So a therapeutic response is to resolve and reduce that tension and lessen the anxiety. So we've talked a lot about de-escalation. We know that verbal and nonverbal skills, those are the nurse's words, their body language, their tone of voice, they're all important skills in client care that de-escalates any crisis. We also have to have a very good supportive team. So allowing, as far as the team, we're allowing that client to communicate their concern. We're utilizing shared problem solving. We're avoiding contradicting the client or acting defensively, applying that therapeutic use of silence, apologizing if appropriate, right? We're following through to resolute the crisis. So you can see that crisis intervention is very, we've kind of talked about that, but making sure that we're going through those de-escalation techniques. So some behaviors and manifestations that can require further assistance. So we know as healthcare professionals, we have to, as nurses, understand when a referral for additional resources is needed. So if our patients are disoriented, significant depression and anxiety, if our patient has a known mental illness, we may need further assistance. If they're suicidal or homicidal, problematic use of substance, interpersonal violence or abuse, or prolonged disruptive behaviors, right? Sometimes we can't do it on our own, and we need to know who we can call on to further assist us. So post-disaster risk for developing mental health disorders, we've kind of hit on some of these things, right? These mental disorders may develop in days, weeks, or months following a disaster. We've talked about each of those. Prevention in healthcare is focused on preventing disease or illness from occurring, but stopping the progress of the disorder is typically secondary. Preventing those complications of diseases is tertiary. So when we talk about primordial or prevention, this focuses on preventing those risk factors from developing. So what do? We address the public health policies, environmental and behavioral risk factors. So developing positive lifestyle habits, that's a great example for our kiddos, right? Primary prevention includes strategies aimed at supporting wellness and creating a safe and healthy environment. Let's see, secondary prevention supports those at the highest risk for developing a mental health problem. So our focus is on early identification, early intervention, and support for those people that have some trauma. And then tertiary prevention focuses on the persons diagnosed with those existing health or mental behaviors, helping them improve quality of life and well-being, and hopefully preventing complications. So nursing process, right? We always go through our nursing process. The first thing we start with is assessment. We're going to collect histories. We're going to obtain information regarding prior mental health concerns, family history, mental health illness, what's the severity of the manifestations, what does their social support look like, their coping styles, do they have any available resources, past or current medication, what's the risk for violence or self-harm. So again, right, that initial assessment questions is about traumatic experience that should be general and a pace that does not increase the anxiety or stress. So then we've collected all of our data. We have to analyze what we've collected and then move forward. So analysis of those cues. We're going to review each symptom domain. Symptom domains of trauma include what were the behavioral cues that we saw. Did they have any affective or emotional cues, cognitive cues, physical cues? Right, to help evaluate the risk for either violence, self-harm, or harmful behaviors towards others. Affective or emotional cues, again, are they at risk for suicide or homicidal thoughts? So just looking at those different cues. And then we need to prioritize what is most important here, right? If we are if we do a screening and it's positive for suicidal ideation, command hallucinations, homicidal ideations, then we have to ensure a safe environment. We have to notify the members of our team, right? So if our prioritization is about safety, then we need to make sure all those safety plans are in place. Then we can generate some solutions, right? Those are those SMART goals that we're going to make for our patients. I'm going to let you guys read that one. We're going to intervene, right? And then we're going to evaluate. How did our interventions work? The trauma is going to be slow and challenging process. So recovery is going to have to be very supportive, compassionate relationships that build on strengthening those coping skills. So when we evaluate those outcomes, how did our client respond to the plan of care? How did they respond to those interventions? Getting some feedback from the interdisciplinary teams about the client. And then some pharmacology and therapies that we can think about. We've kind of talked about each of those previously, but we can talk about cognitive behavioral therapy, right? It's focusing on the relationship between what's the client thinking, feeling, and behaving. The goal is to change the patterns of thoughts, feelings, and behaviors. When we think about prolonged exposure therapy, we're slowly teaching that client to approach trauma-related memories, feelings, situations that they've really probably tried to avoid for a really long time. Cognitive processing therapy is, again, that cognitive behavioral therapy that can help the client change or alter their beliefs about the trauma. We've talked about EMDR. And then as far as pharmacotherapy, there's no like memory repairing medications that are going to fix or wipe out the traumatic memory for our patients. So a lot of times if we are prescribing medications, it's those SSRIs, those SNRIs, maybe some benzos to treat some anxiety related manifestations. And that concludes this chapter. If you have any questions, you can shoot me an email or we can chat about it in class. Thanks, guys.